Hello, and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for April 19th, 2023. Thank you for joining us this month. My name is Kirsten Ambrose, and our presenter today is Jeffrey Driban. Dr. Driban is an associate professor in the Department of Medicine at Tufts University School of Medicine and a member of the special and scientific staff at Tufts Medical Center. His research explores novel biomarkers and imaging markers to facilitate more efficient clinical trials and to better understand osteoarthritis pathophysiology and potential endotypes. Dr. Driban also aims to raise awareness about osteoarthritis and promote primary and secondary prevention strategies. He serves as the past chair of the Osteoarthritis Action Alliance and chair of their secondary prevention task force. The title of today's presentation is Preventing Osteoarthritis After an Anterior Cruciate Ligament Injury, an Osteoarthritis Action Alliance Consensus Statement. Welcome, Jeff.
Thanks, Kirsten. And it's a pleasure to be here to have this opportunity to introduce our new consensus statement. The papers related to the consensus statement will be published in the Journal of Athletic Training in early May. It'll be published as two papers. The first is a summary document that'll have a table reviewing the key recommendations, and it'll be accompanied by our evidence review, which will go into details about the methodologies we used, as well as the evidence that we used to justify our recommendations and any dissenting opinions towards those recommendations. Knee injuries are a growing problem in the United States, representing over 600,000 emergency department visits per year. And despite the emergence of evidence-based injury prevention programs, we continue to see an increase in the incidence of knee injuries, including ACL injuries, especially among adolescents, males, and females. In fact, 1 in 3 ACL reconstructions are performed in high school or college athletes. The problem with these injuries is that while many people have a successful outcome after a knee injury or an ACL injury, for at least 1 in 3 people, the knee injury represents a catalyst to living with knee osteoarthritis for most of their life. This will mean they'll experience decreased quality of life, decreased physical activity, decreased physical function, as well as psychosocial concerns and psychological concerns like depression, economic challenges associated with things like high medical costs, and comorbidities such as cardiovascular disease or diabetes. Each year in the United States, the economic burden of individuals with a history of ACL tears costs us about $7.6 billion. While we often think about the problems associated with osteoarthritis as something that happens years after an injury, we actually can see that things are happening fairly early after an injury. For example, in this graph, we have a blue line that represents patient-reported pain, and also in orange, the patient-reported quality of life over time in different cohorts. What we see is over the course of the first year after the injury, patients are continuing to improve in both pain and quality of life. But then they begin to plateau at where you're seeing these dotted lines. The dotted lines represent the level at which people often report an acceptable symptom state, meaning there's a lot of people above the dotted lines that are likely experiencing acceptable symptoms, but some patients are going to be falling below the acceptable levels of symptoms. And in fact, if you ask a patient specifically, do you perceive your symptoms as being acceptable? At 12 and 24 months, about 1 in 3 individuals would suggest that their symptoms are unacceptable. And 1 in 10 would even suggest that their treatment was a failure. And this persists over up to 10 years. And by 10 years, we know that about 1 in 3 individuals will have radiographic signs of osteoarthritis. And it still remains a little unclear today whether or not the people who are reporting unacceptable symptom states early on are the same people who are showing radiographic signs of disease later. All of this should raise awareness for the need for secondary prevention after a joint injury. And the goal of secondary prevention is to identify an illness or disease at its earliest stages so that we can start treatments to halt or slow its progression towards long-term problems. So for secondary prevention of osteoarthritis, our goal is to help preserve quality of life and wellness for the patient's rest of their life. So if you think of a 20-year-old who tears her ACL, The data suggests that she has a 1 in 3 chance of having persistent symptoms starting within the first year or two. And then the data also suggests that there's about a 1 in 3 chance of having radiographic osteoarthritis within 10 years of that injury. Furthermore, we've seen evidence that on average, individuals with a history of an ACL or a knee injury will have an earlier diagnosis of osteoarthritis than their peers, typically around 55 years of age. And they're also more likely to receive their joint replacements a little bit younger than their peers, on average around 65 years of age. While knee replacements are a very effective surgery, we do need to acknowledge that there are some patients after receiving a joint replacement that will continue to have persistent symptoms. So the person who tore her ACL at 20 could potentially be living over half her life with chronic painful conditions that's impacting their activities of daily living and their quality of life. And while we are very effective at delivering care for these patients during the first year after their injury, we tend to lose them in our healthcare system after the time they get cleared to return to activity until they've been diagnosed with osteoarthritis. And so we kind of have these lost decades of care where patients may be experiencing symptoms, but are not engaging in the healthcare system for those symptoms. One of the challenges to secondary prevention after a joint injury is that we lack a lot of high quality evidence to inform clinical practice. In fact, if you look at the National Public Health Agenda for osteoarthritis, you'll find very little about secondary prevention, partially because there's a lack of that high quality evidence from large clinical trials to help inform what we could do from a public health perspective. Fortunately, there is the ability to develop a consensus statement to help fill this void. This consensus statements offer a unique role in emerging fields where we may lack the evidence to inform clinical practice guidelines. Consensus statements leverage expert opinion and clinician experience to offer recommendations. So our goal at the Alliance was to provide clinicians with secondary prevention recommendations that were meant to reduce the risk of osteoarthritis after a person has an ACL injury, and to provide insights into areas that need more research. To do this, we started off by sending out electronic invitations to the OA Action Alliance Steering Committee and Primary Prevention Task Group. These groups include representatives and members of the American Medical Society for Sports Medicine, Arthritis Foundation, Osteoarthritis Research Society International, U.S. Bone and Joint Initiative, and the National Athletic Trainers Association, as well as other organizations. We encouraged all of the recipients to share the invitation with contacts that they thought may be interested. We identified 29 members, 24 of whom were from 18 institutions in the United States. We had 4 OA Action Alliance staff members working with us and 1 member from Finland. The task group consisted of athletic trainers, physical therapists, psychologists, orthopedic surgeons, and sports medicine physicians. I won't go into full detail, but I wanted to kind of paint a picture of the timeline for things. We initiated our process in the spring and summer of 2020, where we had our initial meetings. We then broke up into subgroups in the fall of 2020 to start our writing process. We went through 3 rounds of voting over the next few months and with iterative revisions. And then we worked for about a year of harmonizing the text, writing dissenting opinions, seeking some feedback from members that weren't involved in the original writing, and then seeking full approval from the task group and the OA Action Alliance Steering Committee. The 2 papers were peer-reviewed and will be published in May for the Journal of Athletic Training. And over the next few years, we'll be focused on disseminating and developing new resources to help people implement these recommendations. And in our documents, we suggested that the consensus statement should be revisited in 5 to 10 years so that we can decide whether or not we need to revise the consensus statement. During our initial meeting, we decided that our target population would be people up to 40 years of age. We set this age limit because it would capture most of the people who experience an ACL injury, but also eliminate people who are more likely to have osteoarthritis at the time of their injury. We agreed to focus on the time period from the ACL injury until a diagnosis of knee osteoarthritis, when people could refer to treatment guidelines for knee OA. This means that we're capturing both the year at which the person is usually under a well-supervised care for their ACL injury, but also that time period where we often lose people to the healthcare system, even though they may be symptomatic. Our short to midterm goals for clinicians were to promote a patient's role in shared and informed decision-making to help foster informed consumers, educate people about their injury and recovery, coping strategies, maintaining or improving self-efficacy, the importance of adherence, stress management, and goal setting. We also wanted to optimize physical activity, prevent or reduce chronic symptoms, prevent future knee injuries, and reduce psychological stress associated with the injury, return to activity, communicating with clinicians, and other sources. Our overarching long-term goal was to provide evidence and treatment strategies to help prevent or delay the onset of symptomatic osteoarthritis, prevent osteoarthritis-related disability, and improve quality of life. We also wanted to make recommendations about key outcomes that should be monitored and interventions to consider. Specifically, we agreed to focus on education, exercise, exposure therapy, mindfulness therapies, secondary injury prevention, the use of technology, and coordinated care strategies. As we started to write the document, we broke up into 9 subgroups that tackled drafting recommendations and the supportive text to justify those recommendations. We then completed our first round of voting, in which we had 22 members vote. They also provided feedback on the recommendations and supportive text. The subgroups were then asked to revise the recommendations and supportive text based on that feedback. We then completed a second round of anonymous voting. Again, voters had an opportunity to provide feedback, and we had 21 of the 22 people who participated in the first round vote in the second round. After this round of voting, the subgroups decided that it may be helpful for us to have a virtual meeting to review some of the wording and to flesh out some details as a group. So we had our virtual meeting. During that call, it was decided that the psychological interventions recommendations should be revised and reorganized. And so the subgroup worked on that, and then we completed our third round of voting, which everybody who participated in the second round voted in the third round. Finally, we worked to organize the final documents. We reviewed the documents as a group, and we also sought out approval from the task group as well as the OA Action Alliance Steering Committee. We defined a consensus as having more than 80% of our voting members supporting a proposed recommendation. If a voter could not support the current wording of a recommendation during the first 2 rounds of voting, we asked them to provide comments and recommended changes to the text. If after the third round of voting, someone was not supportive of the recommendation, then we offered them a chance to write a dissenting opinion for the paper. If more than one task group member had a dissenting opinion, we worked with them to harmonize their text into a paragraph or 2. Overall, we initially started with 16 preliminary recommendations that covered a range of topics, including patient resources and education, rehabilitation programs for safe return to activity, psychological well-being, regular physical activity participation, assessments, patient support programs, and use of technology to support recovery. All of these achieved consensus, except for one, which was related to cognitive behavioral counseling, which fell 1 vote short. As we start to look at these recommendations, we find that we suggested that we need to provide resources that healthcare providers can distribute to a patient. These resources should explain their risk of osteoarthritis and how to reduce the chance of osteoarthritis and its worsening. We also encourage clinicians to improve their communication with patients and to provide resources and to communicate with patients at the time of injury, but also at regular intervals after their injury. To do this, we acknowledge that healthcare professionals needed to have educational opportunities on how to best educate patients about osteoarthritis prevention. This could occur at entry-level education programs or through continuing education opportunities. These educational opportunities would focus on how to educate and communicate with patients about osteoarthritis, which can be particularly challenging since we're talking about a younger population who may not be thinking about long-term outcomes. We also encourage the development of a toolkit to help caregivers identify a patient's willingness for rehabilitation and a patient's preferred mode of obtaining self-management resources. We thought that this could be achieved with 2 to 4 questions that identify a willingness to manage their injury, identify limitations to obtaining, learning, and retaining these findings, and to help determine the best delivery mode for information, such as handouts, videos, or mobile applications. Not surprisingly, we also encourage that individuals after an ACL injury should undergo a supervised, comprehensive, and progressive rehabilitation program to address key concerns before return to activity. These may include impairments and neuromuscular deficits, quality of movement, knee range of motion, quadriceps muscle strength and performance, and functional performance. Furthermore, before returning somebody back to sport, we encourage individuals to start a sport-specific training program that gradually progresses and offers an opportunity for the patient to restore their metabolic conditioning, build tolerance to chronic training loads, and adopt desired movement strategies. We also want to encourage people after an ACL injury to be physically active and to meet the physical activity guidelines for Americans in the second edition. During the rehab process, we also believe it's important to consider psychological skills training that can be part of the short-term and long-term care plans for an individual to help prevent re-injury, improve overall health and wellness, and encourage engagement in and adherence to physical activity. Psychological skills training fosters focus, acceptance, attentional control, decision-making, and a mindful state. These can be delivered by various trained clinicians, including athletic trainers and physical therapists, who can teach these skills, such as mindfulness meditation, relaxation skills, self-knowledge mastery, mental imagery, goal setting, and self-talk. We also believe that graded exposure therapy could be added to therapy programs after an ACL injury or reconstruction to overcome fear and prevent re-injury. Graded exposure therapy provides positive reinforcement when a patient completes a fearful task without experiencing pain or injury. We also felt it was important to monitor patients regularly after an ACL injury using a comprehensive approach, including patient-reported outcomes, performance-based measures, and measures of disease progression, such as imaging. In our evidence review, we offered tables that summarize some key outcomes that could be considered both in the clinic and in research environment. We also believe that there was a need for a multifaceted return to sport test battery to inform a shared decision-making process among all stakeholders when determining readiness to return to play. This could include quadriceps muscle strength assessment, performance-based metrics like single leg hop tests, as you see in the figure, and patient-reported knee function. We also advocated for multifaceted preventive training programs that include strategies to improve agility, balance, flexibility, strength, and movement quality in order to reduce the risk of secondary injury. While in an ideal scenario, this person would be returning back to a team that is already implementing an injury prevention training program, we acknowledge that that might not always be the case. And so there is a need to offer that patient specifically a program if they don't have one with their team. Within our resources, we suggested that the Remain in the Game toolkit offered by the OA Action Alliance could be a framework that is used to help develop an injury prevention program for these patients. We also suggested that organizations should optimize socially and supportive environments for patients, such as athletes, service members, or employees, but also providers, families, and caregivers. This can be achieved by recognizing and providing support for psychosocial stressors during the rehabilitation process, including injury-related stigma, uncertainty regarding their return to activity, and threats to personal identity. This type of social support can help protect someone from stressors, and it can improve their adherence to a rehabilitation program. We also believe that leadership should normalize the rehabilitation experience by including peers, such as teammates, in the rehab experience and offering more support. We had 2 recommendations regarding technology. The first was to use technology to enable individuals with a knee injury to monitor their physical and psychological well-being over time. It can also be a tool for accessing evidence-based educational materials developed specifically for their needs. And it can be a way of engaging in health promotion. We also acknowledge, though, that healthcare professionals should consider the ethics and effectiveness of how and which technology is used for monitoring health outcomes and osteoarthritis prevention after a joint injury. Finally, to pull all the recommendations together, it may be helpful to deploy an interdisciplinary, coordinated, patient-centered care strategy to comprehensively address the needs of patients with a history of knee injury. As I mentioned earlier, there was one recommendation that did not achieve consensus, and that was regarding cognitive behavioral counseling being used to promote patient engagement with therapies and exercise to prevent re-injury, improve overall health and wellness after an ACL injury or reconstruction. Cognitive behavioral counseling focuses on efforts to change thinking patterns, to overcome flawed or non-helpful ways of thinking, learned patterns of unhelpful behaviors, and barriers to coping with psychological problems. Cognitive behavioral counseling is typically administered by trained, certified mental health specialists rather than other clinicians that may be trained to do it, such as athletic trainers or physical therapists, which could do psychological skills training with patients. In the dissenting opinion, the task group members acknowledged that there is a theoretical basis for this recommendation, but they believe that the benefit for this population is still too unclear and that the language of the recommendation was too strong. As we wrap up looking at the recommendations, it is important to keep in mind that these are not formal clinical practice guidelines because they lack high-quality evidence, but they are based on the best available evidence from the literature and personal experience of the task group. Keeping that in mind, though, it is worth mentioning that the members were predominantly based in the United States. So if you want to deploy these recommendations in other healthcare systems, it's worth considering how they may need to be adapted for other countries. Our next steps are to promote the consensus statement through press releases, activities such as these webinars, podcasts, etc. We also intend to develop infographics for clinicians and patients. We intend to develop consumer information and educational resources for the patient. Furthermore, we want to develop educational resources for healthcare professionals. We will create a website for the OA Action Alliance, and we'll also potentially develop a mobile application. We also intend to write a white paper on how to develop the coordinated care program and some of the pitfalls we may need to consider as people develop these programs. We also hope to collaborate with authors of other consensus statements, for example, the OptiKnee consensus statement, which came out in the last few months. And if you're interested in participating in any of these steps, please let me know or the OA Action Alliance staff know. In summary, we hope that we're providing clinicians with secondary prevention strategies intended to reduce the risk of osteoarthritis patients after an ACL injury. We're adopting a comprehensive approach to address physical and mental well-being. And we hope to foster more discussion on how we can help ensure the long-term wellness of people after any joint injury, not just after ACL injury. We hope to spark discussion about what patients need to know to be informed consumers in a healthcare system and guide research because each recommendation still requires high-quality evidence to justify and refine that advice. And finally, we hope to raise awareness among clinicians and researchers and encourage them to take steps to mitigate the risk of osteoarthritis after an ACL injury. Just wanted to share with you the OA Action Alliance website, our social media ways of contacting the Alliance and myself and my email. And I wanted to give a little shout out to the Remain in the Game toolkit, which we mentioned earlier, which is a primary injury prevention toolkit developed by the Osteoarthritis Action Alliance, as well as the OA Care Tools, which is an educational toolkit for preventing and managing osteoarthritis. As we open up the floor to questions, I just want to acknowledge the 29 members that helped draft these consensus statements. It's been a great group to work with, and I'm looking forward to continuing to work with them as we develop strategies to help disseminate and implement the recommendations. So thank you to all of our task group members, and I'm glad to answer any questions you have.
Thank you, Jeff. This is really an impressive body of work and really, I think, an important first step in developing some more tools and resources. You alluded to some as we wait for some questions to come in. I'll ask one. Some next steps that you're looking ahead to, and there's so much that could come out of this statement. And I wonder if you could give folks on this webinar or just in general, how can people become involved? I think there's a lot of opportunity to work with the OA Action Alliance and this task group to develop some of those next steps and help some resources and tools come to fruition. So what would you tell people who might want to be interested in getting involved?
This is a great time for people to get involved with the task group as we're starting to think about developing new tools and resources to help people implement these recommendations. So I would encourage them to reach out to me. My email was on the prior slide. They can also reach out on the OA Action Alliance website to the Alliance staff. Our next steps is we're in the process of working on infographics. We're also starting to think about presentations at conferences to help provide educational material. We're also going to be thinking about over the next coming few months, the opportunities to educate patients and what kind of resources we could develop for them. And you saw the list of things that we're thinking about doing. It'll be kind of a thing that we'll work on over the next few years. And if people don't necessarily have the bandwidth now because they have other commitments, I would encourage them to still reach out to us and we can put them on our email list for the task group. And when they see that we're transitioning to new activities, they're always more than welcome to jump in if they're interested in specific topics.
Well, one thing comes to mind too. Thank you for that. That's helpful, I think, for people who are listening. Back in March, you and several of us participated in a collaborative workshop with the Osteoarthritis Research Society International at their meeting. Some of the folks on this webinar may have been there. But can you give a sense that puts me in the mind of research collaborations and opportunities to sort of cross-cut between public health and our colleagues in research? Some of the things that we talked about during that breakfast workshop, Jeff, can you give some thoughts to, different ways that researchers might also might be interested in working with us from a collaborative standpoint?
Yeah, certainly. So similar to some of the resources that we talked about at the Osteoarthritis Research Society International meeting, as you think about it, we're going to be developing educational material for patients and healthcare providers. And while we're focused a lot on developing the resource and helping it disseminate out there, the resources that we're developing could also be incorporated into future projects. For example, if you wanted to test a coordinated care strategy, you could work off of some of the stuff that we're currently thinking of and either adopt it for your own trial or use what we're proposing as a model. Similarly, the things like the mobile applications that we mentioned that we've conceptualized, we may be in the process of developing such an application or a toolkit, and the researchers out there could potentially be involved in developing it. Or instead of reinventing the wheel at their own institution, they could potentially utilize the resources that we will have in their environments. And I think this is an exciting time for researchers and clinicians to be engaged in this process because there are opportunities to be both on the entry-level side of building these resources, but also on the other side of testing and disseminating these resources or incorporating their resources into what we're developing as a toolkit.
Thank you. That's very helpful. And we've got one question in the chat that I would like to bring in, but I also recognize that we're at the 30 minutes for our time. So I'm just going to interrupt and give a quick plug for those who need to hop off for our next month, May 17th, 2023. We have a lunch and learn with Nancy Baker, who is also from Tufts University, who will present on using virtual reality with people with arthritis. So do check in on May 17th and keep an eye out for that. Katie just popped a poll for today's webinar, so if you'll take a minute before you hop off to answer those questions. But to the question that came in the chat, I think this is interesting. What data exists that informs us that we can change the trajectory? Is some of this dictated by initial trauma followed by surgical trauma? It may be dictated by the presentation.
Yeah, so we have, if you look when our evidence review comes out, you'll see that a lot of the recommendations are based on some of the impairments that we're seeing that should be addressed. And I think a lot of it is intuitive things that when a lot of people see them, they're kind of like, of course, is what we should be doing. As for high quality evidence, that would suggest, if we implement X, Y, and Z, like if we do the cycles, add psychological skills training to our existing rehabilitation program, will that have a dramatic impact on symptoms? There is some short term evidence that it could be effective, but we clearly need more long term studies. And I think one of the interesting things that comes up with this paradigm is we often conceptualize the need for a secondary prevention trial to necessarily be this long duration thing because we're trying to observe whether or not we're preventing the onset of symptomatic osteoarthritis. But in many ways, these patients need short-term benefits as well. If we can demonstrate that doing psychological skills training, just as an example, with a well-structured supervised program can reduce a patient's pain and improve their quality of life, then that is a positive outcome, even if we don't know if it's altering their risk for osteoarthritis. And we do know that with some of these recommendations, for example, somebody who performs well on a return to sport testing assessment is less likely to experience a second ACL injury. And so for some of these recommendations, yes, we have the evidence to believe that if you implement these recommendations, it'll have a profound effect on the person's wellness. But certainly for some of these recommendations, there's still a lot of evidence that we need to gain both in the short term and long term.
Excellent, thank you. I don't see any other questions, but there are quite a few comments and notes of appreciation for all the good work. So I will echo that. Thanks to you, Jeff, for taking the lead on all of this work. And thank you for presenting our webinar today. Thank you, everyone, for taking time out of your day to attend, and do hope that you'll look ahead to the May 17th webinar and the consensus statement coming out. Early May is the forecast for Journal of Athletic Training. So we'll keep our eyes on that and shout out whenever we see it. So for now, I will wish you all a very good rest of your day. Thank you so much.